All right, good morning, everyone. Well, thank you for having me. I'm really excited to come and talk about my field, which is vascular anomalies. I'm going to be presenting today on behalf of our whole team that helped to put this presentation together. I'm going to figure out how this works. There we go. So today I just have three main objectives. One is to give a brief overview of vascular anomalies because it's a big catch-all term that has a lot of smaller buckets. I want to talk about the genetics in a way that's interesting and that is helpful and useful in showing how our field is advancing. And then based on those genetics, I want to talk specifically about some really exciting new targeted molecular inhibitors that we're using. And the key takeaway message for today is these patients can have a variety of symptoms, a variety of presentations. The data and evidence on how to best treat them and how to best diagnose them is changing literally daily or weekly. So I really recommend if you have a complicated patient, reach out to a multidisciplinary vascular anomaly center to get some advice to help co-manage that patient. So first, a brief overview of vascular anomalies. And I want to start with a few pictures. So these are three patients we've seen in our center. Each of them has a lip lesion that looks pretty similar. Once we did more diagnostic workup and some genetics, we found out the lesion on the left was an arteriovenous malformation, and it had a germline RASA1 mutation. In the middle was a venous malformation. We didn't do any genetics on that one. And then on the right was a capillary malformation that had a somatic PIK3CA mutation. That might all sound a little Greek right now. The reason that matters is that the patient with the RASA1 mutation needs to have screening because they're at a higher predisposition of having AVMs throughout the brain and spine. The patient with the venous malformation in the middle would need possibly sclerotherapy, but wouldn't need any additional screening. And the patient with the PIK3CA mutation needs to have the rest of their body screened to make sure they don't have another overgrowth disorder. But they look very similar when they come in. And then another example, these are three patients that have a big torso capillary stain. And when we did further diagnostic workup, the patient on the bottom left had an AKT1 malformation, or AKT1 mutation. The patient in the middle had a PIK3CA mutation, and the patient on the right had a GNAC mutation. All of them somatic, which I'll explain what that means and why that's significant in a second. But the reason this matters for these patients is the patient in the middle with that distribution needs to have every 3 months ultrasound of the kidneys to make sure that she doesn't develop a renal tumor, whereas the other two don't need that type of workup. And so to take a step back, vascular anomalies is a big catch-all term that just is a spectrum of lesions of vascular tissue. This really splits off into two different groups. One is vascular tumors. The most common that I'm sure the vast majority of you have seen are hemangiomas. So infantile hemangiomas, involuting, non-involuting, congenital hemangiomas. Those all are vascular tumors. It's an actual hyperproliferation of endothelial cells that cause more of a tumor than a malformation. There's also rare things that are kind of borderline malignancies, like KHE, and other types of disorders like that. And then there's the frank malignancies that would predominantly just be seen by an oncologist. And what I'm going to spend more time talking about today, though, is vascular malformations. And this is where there's a defect in the formation of the vessel that causes an overgrowth and a tortuosity of the vessel itself. And this can happen as a pure lymphatic malformation, a pure venous malformation, a mix of lymph and venous channels, arteriovenous malformation, capillary malformation. Any of the tubes that we have in our body can have a mutation that causes them to grow abnormally. And as I go through this, I'm gonna frame this again as the way that our multidisciplinary team works. And so at our clinic in St. Louis, we have a team of people that have a dedicated interest in vascular anomalies, and it includes ENT, dermatology, hem-onc, genetics, interventional radiology, plastic surgery, radiology, surgery. We do inpatient and outpatient consultations because for any given patient, they might need no treatment and just close observation, or they might need some surgery and some IR and some prevention of clots and some targeted inhibitors, and it really is individualized to every patient. The other thing that we offer for these patients is a medical home related to their vascular anomaly, where we tell the patients who struggle to find people that have had a lot of experience with these, call us, we will work with you, we'll work with your primary care doctor, and we'll help you to figure out who's the best to help you with whatever problems you're having. But it's helped families a lot just to say, if you don't know what's going on, call our office because we have the resources to help coordinate that care and help navigate along with your primary care doctor. When we think about vascular anomalies patients, the presentations, again, when I explain the genetics, it'll make sense, but it can be broad and varied. It can affect literally anywhere from head to toe. We have a number of patients that have isolated head and neck malformations, and sometimes those malformations are very simple, like this patient right here just has a lymphatic malformation that causes a small disfigurement, but she's never had flares, she's never needed any treatment other than observation. And this is inside of her mouth, which looks relatively clean. This is another patient with a lymphatic malformation that involves her tongue and her oral cavity. She'll have recurrent flares, pain, difficulty swallowing, difficulty eating. This required a multidisciplinary approach to treatment. Similarly, you can have isolated lower extremities. This patient has a mixed venous and lymphatic malformation just around the knee joint, and you can see there's obviously the malformation underneath the surface, and it pokes through with these little lymphatic blebs here, those little red spots. The reason this matters is a couple reasons. One, when these can continue to grow, and if there's a big venous component, you have to make sure that it's not intra-articular. If it's intra-articular, you have to talk with orthopedics and interventional radiology and plastics to think about sclerosing, ablating, and getting those out, because just like almost similar to hemophilia patient, they can have rupture and then have contracture of those joints. We've got a patient who unfortunately didn't make it to our clinic till he was about 9 and had already had several bleeds and now has a permanent contracture in his joint. So early observation, early workup of these is important. The other is that, the other point is that as these venous malformations develop, you can grow very large ectatic vessels that can get clots and create just a highway straight to the lungs. So it's important to note that even at a young age, if they don't have a big, large bore abnormal vein, it can develop, so they need monitoring over time to make sure that you don't develop any high risk of a clot and a thrombosis. And then you can have really diffuse lower extremity, really diffuse involvement. This patient here has a diffuse PIK3C related overgrowth spectrum where both of his legs have diffuse hypertrophy of fat, lymphatic vessels, venous malformations, and you can see he had to have a big resection because his foot was about twice the size as the other foot. So these patients can commonly have flares, which are kind of a mix of infections and just inflammatory trapping, overgrowth, chronic pain, especially if they have asymmetric limbs, and just not knowing where to go to get help. The workup involves, number one, a really good skin exam, because often these patients that have syndromes, they'll have some signs that a really good dermatologist can find, or a really good primary doctor. Ultrasound is really helpful, number one, just to give a quick sense of what's going on. Number two, to see if it's a lymphatic malformation. Are they small cysts or are they big cysts? And that will help us to know whether interventional radiology sclerotherapy would be useful, or if more of a targeted medication approach would work. And then MRI is really important before any intervention, because there are a number of patients that have no findings on the skin surface or just a tiny lymphatic bleb, and then you do an MRI and realize that it's encompassing their entire lower extremity. So before you do any type of surgery, any type of interventional radiology, it's really important to map out exactly what's involved by the malformation. And we'll talk a bit about treatments later, but it really ranges from observation and supportive treatment to a mix of surgery, sclerotherapy, medicine, and then other preventive care. And then next, what I really want to talk about is genetic testing, because this is where the field has really revolutionized in the last about 10 years. So I have a number of patients. I'm a pediatrician, but I see patients up to 40s, 50s, 60s, because there's not a lot of centers that take care of these patients. And they've been told the vast majority of their life, there's nothing we can do for you. We don't have any treatments. We don't know what's causing this. And that's been true up until about a decade ago. So this is a really exciting new era for this field. And the genetics are different than we usually think of genetics. When we think of genetics, we generally think you have a sperm and an egg. One of them carries a defective gene. And then if you inherit that, every cell in your body has that defective gene. That's normal germline mutations. The vast majority of vascular anomalies are actually mosaic. And what that means is that when sperm and egg meet, neither of them have a mutation. And then at some point when those sperm and egg become one cell, splits to 2, 4, 8, 16, etc., at some point between fertilization and birth, in that development, one of those cells will develop a mutation in one of these particular pathways we'll talk about. and then everything that cell turns into carries that mutation forward. And so you can have the exact same mutation that happens either in a different cell or at a different time in development and have drastically different phenotypes. So just as an example here on these pictures, this patient would have had a mutation very late in development, and as a result, it's just a really isolated lymphatic malformation, really probably doesn't even need treatment, just has a little lump that you can kind of monitor, ignore. This patient unfortunately had a cell that was a little bit earlier and involves the face and the airway, and these patients sometimes need an exit procedure after birth, sometimes will need targeted medications, and sometimes will need tracheostomy. This patient here had a mutation that was much earlier, and it's more diffuse throughout the body, and it includes overgrowth of muscles, bones, lymphatic vessels, et cetera. Again, depending on the cell, I've got a patient that has every inch of his body is covered in capillary malformations and broad abnormalities because he must have had a mutation very, very early on. I've got another patient who has a tiny little bump that we look at and say, oh, that's actually lymphatic malformation. Exact same mutation, just wrong timing and wrong cell. And this is a handout I give to my patients, and I'll talk with you through today. This is about the PIK3CA mutation. In lymphatic malformations, this type of mutation is what's causing about 80% of these lymphatic malformations. There are other ones in this pathway and another pathway we'll touch on, but I want to really focus on PIK3CA because this is what has kind of revolutionized our field in the last decade. The way our cells usually work is we have to have a growth receptor to tell cells to grow, to duplicate, to split, to make blood vessels. And in this pathway, when you have a growth receptor that's targeted, it goes through all of these kinases and it ends with mTOR that turns on. And it's kind of a nutrient sensor. If you're in a nutrient-rich environment and you have growth signals, it'll tell your cells to grow. You take away that growth signal, the pathway shuts down and you stop telling cells to overgrow. What can happen in patients with PIK3CA mutations is this gets permanently turned on. And when that's permanently turned on, you have growth and absence of the growth signal. The reason this matters is because if anybody's familiar with renal or kidney or liver transplant, there's an mTOR inhibitor called sirolimus. And what that is, it's like a dimmer switch. We have to have some mTOR or we'll die. But it's a dimmer switch that can slow down that mTOR. And what we found is that we can use the same exact thing in our patients that have PIK3CA mutations, and it can lead to drastic improvements for them. To give a bit of a timeline on this entire pathway wasn't discovered till the 1980s, the role of PI3 kinases in general. mTOR, that last target, wasn't discovered until the 90s. There's actually, if anybody's bored, there's a really interesting Radiolab podcast on the rapamycin, which is the other name for sirolimus. It's a very interesting story. The way that we got mTOR is because they found a drug called rapamycin, and then it bound to something. And so they called it the mammalian target of rapamycin. So usually we have something that we want to target, and then we come up with a drug that targets this. In this case, we named the protein after the drug that sticks to it. So watch that. I don't get any proceeds from Radiolab. But the PIK3CA mutation was actually discovered as a hotspot in a lot of adult cancers, especially breast cancers, about 2004. 2011, 2012 is when we started to see some of these growth pathway mutations in vascular malformations. 2015 is when we first developed this categorization of PIK3C-related overgrowth spectrum, which is, again, patients that got a mutation in PIK3CA and in a different cell at a different time point that leads to this big bucket of phenotypes called PROS. And so, as you can imagine, it's actually a lot more complicated. I don't understand everything on this slide, but I know that there's some people that purport to. There's so many pathways, so many cross reactions, and leading to many different types of mutations. So there's a lot more that we're still learning in this field that I think is going to improve the lives of these patients in the future. This is just one patient to show when you have an early mutation in PIK3CA, what it can lead to. And so you can see she's got overgrown fingers. She's got overgrown toes, which often causes orthopedic issues, and they'll have to have resections, special shoes, diffuse capillary stains, and then if you were to look inside of her, you would see a lymphatic involvement in her spleen, and then she would actually have some overgrown kidneys, and that's what you have to monitor for Wilms tumor progression. these are some other patients, just again to give you some pictures of what we often will see. And now that I told you, just like everything in med school, you tell people how it is, then they learn it, and then you say, well, that's not actually how it is. So in 2011, we decided that the concept of PIK3CA-related overgrowth spectrum was too broad, and we were lumping things into it that didn't really fit. And we said, really, to have pros, you need to have overgrowth, like that patient with the big toes, big fingers. But there's other things like isolated venous malformation, a lymphatic malformation, where you have an overgrowth of a particular tissue, but not a diffuse overgrowth. So now the new proposed naming scheme is PROS, PIK3CA-related vascular malformations, and then there's another category of PIK3CA-related abnormalities that are not vascular, and we call them overarching group PIK3CA-related disorders. So that's my brief genetics, and everybody's still awake, so thank you for that. Now I want to talk about what the genetics teaches us about treatments. And I'm trained as an oncologist, and this is very different than cancer. Cancer is predominantly, we need to get rid of it, and we need to kill every single cancer cell off, or eventually it's going to kill the patient. And to do that, we have very regimented treatments where we say every patient is going to get the exact same treatment. Vascular anomalies are very different, and we have to make a really case-based decision with every patient about what their symptoms, quality of life are, and what their functional impairments are to weigh the risks and benefits of different treatments. The types of functional impairment we think about are things like airway compromise, challenges with eating, swallowing, vision impairment. Sometimes these malformations will occur right behind the eye and create pressure. Sometimes you get coagulopathy, consumption of platelets, or other vessels. Sometimes we'll get a lot of dumping of chylous fluid into the lungs. And so you have to take into account those functional impairments. But even in the absence of those, some of these patients can have chronic pain, swelling, disfigurement, flares, and a lot of psychological distress. So we have to take all of that into account when we figure out what the right treatment is. And there's 4 main pillars of treatment. One is conservative, which might be the best treatment is no treatment. Just observing, doing some compression, doing lymphatic massage, finding an occupational therapist or a physical therapist who's got specific training in lymphatic massage. Sometimes it's sclerotherapy, sometimes it's surgery. Surgery is 20 years ago, almost all these programs were run by plastic surgeons. Nowadays, because of the advent of sclerotherapy and targeted inhibitors, surgery is less and less needed, which is a great thing for our patients. Medical therapy, there's chemotherapies, there's steroids, antibiotics. The one we're going to really talk about today are targeted inhibitors, and then there's monitoring for long-term complications. And just to say briefly, I had a patient who came in and was in her 40s and had a venous malformation up in her nasal cavity and was told, well, there's nothing we can do, so she stopped seeing a doctor for about 25 years and then came back, and it had actually eroded the base of her skull and had to have a big ablation and surgery and reconstruction. So even, it's really important, even patients that are in their adulthood, to realize we have things we can potentially offer to them. So with targeted therapeutics, I want to tell the brief story of how PIK3CA helped us. Number one, we're really lucky that adult cancers also have PIK3CA, because pharmaceutical industry is not going to pay to develop things specific for vascular anomalies. Breast cancer has PIK3CA, and so there have been drugs that are developed to target breast cancer, and those are starting to trickle down into vascular anomalies. But this is looking at sirolimus therapy. So this is a patient that was presented in 2010 at our international conference that had a vascular tumor called KHE. And you can see it was horrendously swollen, big, threatening amputation, threatening the life of the child, consuming all of the platelets. And they started sirolimus as a last ditch after everything else failed, and you can see the apparent improvement over time, and the labs followed that. This led, and thank you to Denise Adams who gave me these slides. This led to them to treat 6 other patients and publish a case series where they treated 6 patients with sirolimus after all their treatments failed. They all had a response to that therapy. This got the drug companies interested and said, well, maybe we will fund a trial. And so they did 61 patients with vascular anomalies, treated with sirolimus for a year. 47 had a partial response, and this was before we had genetic testing. So this was all comers. 3 had stable disease, and 7 had progressive disease. So patients that had failed literally every treatment option out there are having responses. And it's overall pretty well tolerated. There's mouth sores, there's some diarrhea that patients can have, there's immune suppression. This is a most recent study from last year that looked at a single site retrospective, had 113 patients with vascular malformations that were treated with sirolimus. And they found that about 10% had a serious adverse event, of which the vast majority were infectious and actually viral infections. So that's why it's important if patients are on sirolimus that we know if they're having fevers so we can modify for that. This is just one drug. As you can see, there's a whole other pathway we didn't talk about, but there's different inhibitors that are being tested in different areas. The exciting thing, about a month ago, this drug, alpelisib, was actually just FDA approved for vascular anomalies. So this is the only drug that's ever gotten specific FDA approval for a vascular malformation, and that's very exciting. The unexciting thing is it costs about $32,000 a month to insurance. So that's what we're trying to work through now. And that, unfortunately, is about twice what it costs if you're getting it for chemotherapy. That's another talk. But it's really exciting. We've got clinical trials across the country that are going on. And we've actually, in the last 3 or 4 years, started a consortium called Canvas. And this is 23 different multidisciplinary centers across the country that all coordinate to try to get enough of these patients with rare diseases to do clinical trials and advanced treatments. And so my main takeaways is that this is a really exciting field that's expanding. We've got clinical trials, we've got drugs that we can use in combination with other multidisciplinary therapies. Each patient is going to have a unique risk-benefit ratio and a unique need for treatments and or observation. And we need a multidisciplinary approach. We love working with primary care doctors. I have trouble keeping up with the updates in this very small, narrow field, and I focus explicitly on it. It's not fair to ask primary care doctors to keep up on it. We want to figure out how we can best work with primary care doctors to create a combined medical home for these patients. And with that, I'll say thank you, and if anyone has any trouble finding vascular anomaly specialists, I'm leading another study where we're mapping across the country who takes care of these patients. So I'm always happy offline to help anyone with thoughts, ideas, or finding other specialists to refer to. Thanks so much.